She's fierce, she's loving, she's a boss, she's giving sisterhood, support and service. Mocha Mom. She's fierce, she's loving, she's a boss, she's giving sisterhood, support and service. Mocha Mom. She is, yeah. She is Mocha Mom. She is, she is Mocha Mom.
Good evening, Mochas and friends. I am Quay Noel Kelch. I am the National President of Mocha Moms Incorporated. We are honored and overjoyed to have you here with us tonight. Welcome to Understanding Genealogy and the Importance for Mothers of Color in Medical Research in partnership with the National Institutes of Health, All of Us Research Program. We are happy to have you here tonight. I know all of you all have busy schedules, so thank you so much for taking time out of your busy schedules to spend some time with us. For those of you all who don't know, Mocha Moms is the premier voice for mothers of color. Through chapters nationwide, in Hawaii, and online, Mocha Moms provide support for women of color as they journey through all phases of motherhood while advocating for them nationally. Our focus is sisterhood, support, and service. We host weekly sister socials, moms nights out, social events, conferences, community service events, and much more. To join our sisterhood and find a local chapter in your area, please visit us at mochamoms.org. So before we jump into our topic for this evening, I encourage you to engage in the chat. You'll see the chat function there. We are going to have Q&A at the end. If you have any questions or comments, feel free to type them in the chat, and we will get to as many as we can once we finish. Mocha Moms is excited to partner with the National Institutes of Health All of Us Research Program. All of Us is working to improve healthcare through research. Unlike research studies that focus on one disease or group of people, All of Us is building a diverse database that can inform thousands of studies on a variety of health conditions. This creates more opportunities to know the risk factors for certain diseases, to figure out which treatments work best for people of different backgrounds, to connect people with the right clinical studies for their needs, and to learn how technologies can help us take steps to be healthier. The All of Us Research Program is part of the broader Precision Medicine Initiative. So tonight, we have the pleasure of hearing from Dr. Karriem Watson, Chief Engagement Officer of National Institutes of Health, All of Us Research Program, on understanding the importance for mothers of color in medical research. Dr. Watson is the Chief Engagement Officer for NIH's All of Us Research Program. He comes to NIH after 16 years in academia and community health. He previously served as the Associate Executive Director of a group of federally qualified health centers in the Illinois area, where he developed a community-engaged and implementation science research program. He was also faculty at the University of Illinois School of Public Health Division of Community Health Sciences. Dr. Watson's research focused on cancer prevention and control, and he previously had a multi-PIRO1, hope I said that correctly, from the NIMHD, looking at epigenetics in lung cancer screening among African-American men, and was funded in a multi-PI project through the NHLBI UG3-UH3, looking at the implementation of evidence-based tobacco cessation in FQHCs. Dr. Watson also received funding from the NCI to develop a citizen science program that engaged African-American men in prostate and lung cancer screening. In addition to his research, Dr. Watson has been recognized as a national leader in community engagement, having served as the past chair of Community Campus Partnerships for Health and being recognized by the Longevity as a community champion. He's also passionate about mentoring and training up the next generation of young scientists, and was recognized by the Chicago Urban League as an innovator in STEM. So I'd like to welcome Dr. Watson.
Thank you so much for that welcome, Quay, and to all the Mocha moms. It is an honor and a privilege to be here today. And it's really an honor and privilege to talk about this important topic of the importance of mothers in biomedical research and the role that you all have. And I would be remiss if I didn't first give honor to my introduction to Mocha Moms was through my cousin, who's more like a sister. When she found Mocha Moms as a new mom and who had moved to a new city and who needed community, and you all served as community for her, a community that she still has to this day. So I want to thank Mocha Moms for the impact that you've had personally on my family and the community that you've provided for her and still provide for her. So thank you all for all that you do. I've literally seen it firsthand at work.
That's awesome.
So now if we'll pull up the slides, I'll walk you all through what we'll talk about this evening. Let me know when the slides are up. Great. So thank you all so much so as was noted in the introduction, my name is Dr. Karriem Watson. I am the Chief Engagement Officer for the National Institutes of Health All of Us Research Program. And tonight I'm going to talk to you a little bit about it takes all of us to end health disparities. But I want to particularly focus on the importance of African-American women in biomedical research and honoring all mothers and mother figures. Next slide. So tonight, what I hope to accomplish is to introduce to some of you all and highlight for others the National Institutes of Health All of Us Research Program and discuss the role of genomic data from underrepresented communities and the role that data plays in advancing health equity research. I also want to highlight the importance of mothers of color participating in biomedical research. And then lastly, I want to demonstrate the potential of All of Us data set by showcasing current research being performed by researchers of color. Next slide. And in addition to me highlighting the role that Mocha Moms has played in my life and the life of my cousin and so many other women of color, I want to start off with a little bit about my why, what drives my work. I'm always humbled at introductions, and you all heard in my introduction that I am trained as a cancer disparities researcher, and I spent over 17 years at the University of Illinois at Chicago at UIC, leading and guiding community-based cancer screening programs. And the reason that work is so important to me is because that work directly stems from my own lived experience. The picture on the far right, the woman in the black turtleneck, is actually my birth mother. And this was taken, I didn't understand it then, but this was taken actually while my mother was going through chemotherapy treatments. My birth mother died from complications of breast cancer when I was just 6.5, 7 years old. And I didn't understand it then, but I have a vivid childhood memory of getting dressed for church and going into my parents' bedroom. As many of you all know, kids are disruptive and they would just walk into your room, right? And I burst into the bedroom and my mother had bandages around her chest. And I didn't understand what happened, but then as mothers do, she explained to me in a very caring way that she had surgery and that, this surgery was to help her get better. And I vividly remember that because it was such a daunting image of seeing your mother with these bandages wrapped around her chest. Of course, later I would find out that she had to have a double mastectomy because of the type of breast cancer that she had. And this was the treatment that was often common back then in the early 80s. And we were from a small town in the Midwest, and we didn't have access to a lot of the innovative medicine that we have today. A lot of the innovation was not there. As I look back, I don't even know if the drug tamoxifen, believe it or not, was available to my mother when she had her breast cancer treatment. And I learned early on the importance of an academic medical center. Now, granted, no one said that name to me as a child. No one said academic medical center, but I remember vividly thinking about hearing my parents talk about, going up to the hospital where mother had to get her care. And my parents are from the deep rural South. My dad is from Arkansas, a small town, and my mother was from Mississippi. And so for them, coming up north was supposed to be starting a new life and starting building their family in these new opportunities, only for my mother's life to be cut short by breast cancer. But I often say that my life is the amen to prayers that went along long before I ever existed. And I'm so honored and privileged that although my birth mother lost her battle to breast cancer, I often feel that she's guiding the work that I'm doing today as a cancer disparities researcher. Only several years later, fast forward, I'm graduating from the University of Illinois Chicago with a graduate degree in public health. And at the time, I'm leading a program, a health ministry at a local prominent large mega church in Chicago. And I was doing a program called Pin a Sister. This Pin a Sister program was meant to get African American women and women of color screened for breast cancer. And so imagine my surprise when my oldest sister stood up to take the pledge to get her mammography. The reason why I said imagine my surprise, because I thought that we had had conversations in my family about risk factors for breast cancer, family history, only to find out that we really hadn't had those conversations. And I did this work. So it was a staunch reminder of in reach. We talk a lot about outreach, but it hit me in the head that day about the importance of in reach, making sure that we take care of home. And I know this message is resonating so loud with so many of you all, because historically African American women and mothers have taken care of everybody else, but often sometimes to their own demise and to the fact that they haven't taken care of themselves. And so when my sister said, I was so busy taking care of dad, because earlier that year we had lost my father to complications from colon cancer and diabetes, and she was one of his caregivers with my other sisters. And so she took the pledge to get her mammogram, and she was diagnosed with early stage breast cancer. And I showed this picture in the middle because that's my oldest sister at my nephew's college graduation. We're a tall family. And so when I think about the fact that my sister is thriving today and doing fine today, my oldest sister, and she was able to be there for her son's graduation, I think about the fact that my birth mother was not. But I'm one of the fortunate ones in the fact that that picture on the left with love and thanks is actually my new mom, my mother, who came into my life shortly after my birth mother died. My dad remarried, and I got a new mom. And lo and behold, my new mother gets breast cancer. But her life trajectory was different because my dad, unbeknownst to him, became a patient navigator. His health literacy increased. He didn't have the conversation where he said my health literacy increased. He didn't call himself a patient navigator, but that's what happened. He learned how to navigate his new wife through the system, my new mother through the system, so that she could get innovative care. And again, I learned early on in life that where you lived mattered. Unfortunately, your zip code, your ZNA could be just as important in your health outcomes as your DNA, what you were born with. And my dad had to make sure that my new mom got adequate care. However, in 2020, while right before the pandemic, we buried my new mom from complications of lung cancer. And although I say it may sound like a daunting story, I actually think that science played a huge role in giving her a better quality of life. Because we found out that my new mother qualified for a new targeted treatment for lung cancer screening. She had lung cancer, was never a smoker, never had any environmental exposures to lung cancer. But she ended up with lung cancer, with a lot of African American women are now contracting lung cancer, and more research needs to be done in that space. But as a cancer disparities researcher, I had access to ask the right questions to make sure that they didn't just start a chemotherapy just on a whim with my mother, but that they started a chemotherapy regimen that actually molecularly that targeted her type of tumor. Precision medicine. Medicine was precise for my mother. And although she made the decision to go off of treatment because of some of the side effects, I say that we were given the gift of choice that a lot of families, particularly a lot of African American families, don't exist. My mother was able to plan her own services, to talk about who she wanted there, who she wanted to do her eulogy, what she even planned it down to what color she wanted us to wear. And that's a gift because she was able to transition with dignity. And science gave us the ability to allow us to have choice. So many families of color, so many African American families don't get the opportunity of allowing science to give them choice. And I've seen in my life where science did not give me the choice with my birth mother. And I've seen in my life where science did give us a choice with my new mother. And so I start off with that why, because I don't just do precision medicine, I actually live it. And I'll tell you even more about my family history later on. But next slide. So that brings us to the All of Us Research Program. So the All of Us Research Program is a historic longitudinal effort to gather data from 1 million or more people living in the United States in order to accelerate research and improve health. And the All of Us Research Program actually stemmed from initiatives started by former President Obama. Back in 2015, President Obama and others identified the fact that medicine was trying to do this approach that was almost like a one size fits all. And we know that that one size fits all approach does not work in healthcare. So President Obama and others wanted to move to set forward an initiative called the Precision Medicine Initiative, where they innovatively thought, what can we do to advance research to make it more applicable to populations who carry the greatest burden of disease? How can we build a research program that takes into account where you live, the food that you have access to, your diet, the stress that you're under, family history, and all these things? And how can we collect data that includes biological data that allows us to learn more about your DNA, what you inherit from your parents, what things you may be susceptible to? How can we couple that data with electronic health records? We can look at how your health has changed over time. Even connect that to survey data, where we ask you questions about social determinants of health and other risk factors you have. No research study had that type of comprehensive data in one place for people, and then made that data readily available to researchers. That's what all of us is set out to do, is set out to fill this critical gap in precision medicine by contributing valuable genetic and health data from communities who have been historically underrepresented in biomedical research. And then to allow that data to be utilized by researchers to be able to ask innovative questions. And we don't use the term in the All of Us research program as hard to reach populations, because as a chief engagement officer, I don't believe that any population is hard to reach. But unfortunately, African Americans and other under-engaged groups are often termed hard to reach. What I say is that we're often under-engaged. And so what you'll hear us use is a term called UBR, underrepresented in biomedical research. And that's a term that we use to talk about the fact that we need to increase the diversity, equity, and inclusion of populations that have been historically underrepresented in biomedical research. Next slide. And these two charts are meant to show you a snapshot of what genomic medicine usually looks like versus what genomic data looks like in the All of Us research program. So on the right, that's a pie chart that shows that big blue circle actually shows the data that most scientists have for genetic and genomic studies that they typically have access to. That data is usually collected from 94% white or European participants. That means that when we go to develop innovative treatments, we go to develop these polygenic risk scores, all these things that are predictive of disease and risk, that those interventions, drug development, screening development, is developed from data that is 94% white or European. What does that mean for the generalizability of disease? What does that mean for people who have diverse ancestry? That means that when we take those medications that are part of genomic studies, that we may not know how those findings will truly impact us because we were not participants in the research. And we were not participants in the research often because of us, because there's a new study that actually showed that the number one reason why African Americans don't participate in research, medical mistrust is huge. We have a historical memory of the United States Public Health Service study of untreated syphilis in the African American. We have a historic memory of the story of Henrietta Lacks. But even with that historic memory, those are not the majority of the reasons why we don't participate. Why we don't participate in clinical trials is because we are not asked at the same rate that our European and white partners are asked. And actually, a study showed that when we are asked to participate, and we're asked to participate from researchers that look like us, we are more than about 50% likely to say yes to that research study. So I want to point that out to say that that chart, that large blue chart, is not blue because we don't participate. It's blue because we don't often have access or awareness to clinical trials. In the All of Us research program, we tried to combat that. This chart on the right actually is more reflective of the US. You see that about 53% of our participants self-identify as white, but 16.9% of our participants are Black or African American, with over 7% of our participants identifying being from more than one race. 16% of our participants being Hispanic or Latino, 3.3% of our participants being Asian American. And we were the first program to even ask about the designation of Middle Eastern and Northern African, and then Native Hawaiian Pacific Islander. And soon we will have data on American Indian and Alaska Native populations that will be included in this. And through intentional community engagement and partnerships with organizations that I'll talk about later that represent the diversity of the US, we've been able to do something unprecedented in genomic research. Over 80% of our participants are underrepresented in biomedical research. And almost 50% of our participants are participants that self-identify as being a member of a racial or ethnic minoritized group. That is unprecedented, and that makes us one of the largest, most diverse genomic data sets. And what that means for precision medicine research is that when researchers use our data to understand how they can advance treatments, advance identifying cures for cancer, and advance research on several diseases, even diseases that impact us, they will have data from people that look like us, data from people who have had similar lived experience, and that data can inform drug development and other interventions for disease. Next slide. In addition to, you heard me say that about 75, over 80% of our population are what we call UBR, underrepresented biomedical research. That's from several categories. We recently had a publication on an overview of cancer in the first 315,000 participants in all of us. So imagine a data set that can walk you through an overview of cancer, but can also connect that data with data on race and ethnicity, data on 1 in 4 of our participants over 65. Also, historically, people who participate in research studies are often from a higher SES, a higher socioeconomic status. 1 in 4 of our participants has an income of less than 25,000. We also know from data that more and more Americans are going to be living with disabilities. As we advance treatment for chronic diseases, more people are living with disabilities and getting disabilities as a result of their treatment sometimes. So 1 in 5 of our, 20% of our participants are living with a disability. And even sexual gender minority, we found out recently that we are the largest secondary data set for sexual and gender minorities, the LGBTQI plus community. That is historic when you think about a lot of the fact that some members that are identified as LGBTQI plus often are displaced from their families. That is still happening. And so many of those community members don't know or have access to their family history. So being able to have access to data from the All of Us research program is so important for marginalized communities. And also the fact that over 50% of our participants are women. Prior to 1993, when we had the NIH Revitalization Act that stressed the importance of including women in research, women being included in research was often an afterthought. And so therefore, when we had the conditions like heart disease, medications for heart disease and other conditions that women face were not developed with women participating in those clinical trials. So we are so excited that more than half of our participants are self-identified as being being female at birth. Again, these are groundbreaking things that have happened because of intentionality and intense community engagement with a myriad of partners that truly reflect the diversity of the U.S. Next slide. So I talked about the social determinants of health. I'm so excited to highlight the work of Dr. Cheryl Clark, who's the Associate Chief of the Division of General Internal Medicine and Primary Care at Brigham and Williams Hospital and Harvard Medical School. Dr. Cheryl Clark helped us to develop our social determinants of health questionnaire. So imagine a data set that not only will let you know if you have a biological risk for breast cancer, or that you may have a family history that may put you at elevated risk for things like colon cancer, or that you may not respond to a certain blood thinner medication the same way certain populations do. Imagine that data coupled with social determinants of health data. We're asking 27 markers of social determinants of health. We're even asking our participants about their experience with discrimination, about their experience in the healthcare setting. Because why? These things are important because they help shape our health experience. So I'm so excited that we have this data being collected in the All of Us research program. And I'm also excited that the collection of that data is being led by an African-American woman scientist, Dr. Cheryl Clark, and others who are doing this work. That's an example of how we're changing the face of how we're addressing research. We even have questions about spirituality. Why? Because someone's spirituality is an important part of their health journey. So we ask that question about, does that impact your health journey, and how will that help you make certain decisions? These are all questions, and this data from our social determinants of health questionnaire will be available to researchers to be able to analyze that data and compare and contrast how certain participants answer questions based on social determinants of health factors that may be impacting their lives. Next slide. And also want to talk about, I talked about the different types of data, but this is a snapshot of data that is so important to MOCA moms and others. This is just an example of what's possible when we're looking at pregnancy-induced hypertension. So looking at this concept of pregnancy-induced hypertension, just let's walk through our data to tell you what's possible. So out of 413,000 plus survey responses, 185,000 participants completed the personal and family health history survey. Of those who completed the personal and family health history survey, 59,000 plus participants reported a family history of high blood pressure. 100,000 participants completed the COVID-19 participant experience survey, and 300 participants reported to be pregnant during the pandemic. 80 reported that they were not receiving prenatal care at the time of taking the survey. So imagine this data being in the hand of a researcher to talk about what we're seeing in maternal mortality, morbidity and mortality, sickness and death at unprecedented rates of African American mothers. This is the type of data that we have from our survey response. We also have data from electronic health record. So imagine that in our EHR electronic health record, over 4,400 women have pregnancy-induced hypertension diagnosis out of the 254,000 records that we have. And we have over 12,000 ultrasounds of pregnant uterus real-time image documentation in our data set. So imagine a researcher having access to that data to be able to better understand what is happening to women of color in the family history and related to pregnancy, related to hypertension and high blood pressure. We need to have better data to understand this concept so that we can begin to mitigate this health disparity. And what's so daunting about the health disparity of pregnancy-induced hypertension is that it's not just related to social determinants of health, because we know from other research, not in our study, from other research, that African-American women that have JDs, MDs, and highly educated are having similar birth outcomes to women, the non-women of color with lower education and lower SES. So when we know that in women of color, SES is not the only answer. Getting education is not the only answer. So what is happening within our healthcare systems that women of color are having poor birth outcomes? We need to have sound data to be able to better understand this. And then even imagine having that data coupled with Fitbit data that we can talk about how many steps are women getting that are in our studies. We had 97,000 participants who had female assigned at birth who were completed data on the daily activity. So we can say, how many steps are women of color getting compared to other populations? And then we can begin to better understand and dissect that and say, they may not be getting as many steps, but talk about the why. We may be able to look at their zip code and say they live in a zip code that's not a walkable community. So these are all things that we need to better understand through research. Next slide. So as a community engaged scientist, one of the things that I'm really excited about is that when you hear community engagement, you oftentimes think of it as a soft science. But in the All of Us Research Program, community engagement is an evidence-based approach that we do. And we use what's called a socio-ecological model to actually coordinate our engagement activities. We have outreach and awareness, education and access, enrollment and retention, participants as partners, and knowledge mobilization. So this event tonight is being hosted by Mocha Moms is an example of us doing outreach and awareness, education and access, and knowledge mobilization. We're doing all of those through this event tonight. But we don't do this work alone. We do this work through a network of over 18 national community engagement partners. And I want to highlight a couple of those really key important community engagement partners. One of the partners I want to highlight is DREF, the Delta Research Educational Foundation. DREF is the not-for-profit research arm of Delta Sigma Theta sorority. So we were one of the first entities of the federal government, the NIH, to fund a community-based organization, to fund a research partner of the Divine Nine that is actually helping us to engage African-American populations, women, and others who have been historically underengaged in research. Also, through our work with Pyxis partners, we've been able to engage community partners. Pyxis has done an amazing job of allowing us to broaden our network of community partners to over 115 community partners. We even had a partnership with the National Baptist Convention USA because we understand the importance of faith-based leaders as trusted messengers in our community. And that list goes on and on with partners that you'll see here. But what the message here is that our engagement awardees and our partners reflect community partners who have been historically underrepresented in biomedical research. Next slide. And this is an example of how can we develop a research agenda that responds to community needs. So we know the pregnancy-related death ratios are 3.2 times higher for African-American Black women and 2.3 times higher for American Indian Alaska Native women than they are for white women. So how can we develop a research agenda that is responsive to that? How can we ensure that researchers that are getting access to the All of Us data are answering questions that are important to our community? These are deaths per 1,000 births. If you look at those deaths for African-American women or Black women compared to other populations, this is a clarion call that we have to do more. We have to make sure that the innovations in science are matching the disparities that we are seeing in our community. Next slide. So, and I can't draw this message home more clearly than what we saw with Serena Williams, where she talked about childbirth being a horrid ordeal, and she's not alone. Research underway using the All of Us data set. We have 2 publications that are looking at pregnancy and maternal health, and we have 218 research projects on pregnancy and maternal health. Scientific questions that's currently being included in the All of Us research program are looking at things like personal predictors of gestational diabetes and pregnancy outcomes, looking at pregnancy outcomes, substance use patterns, and provider interactions. Questions looking at key comorbidities associated with Black maternal mortality and severe maternal morbidity in Black women, and also looking at social determinants of health association with cardiovascular complications in pregnancy-induced hypertension. These are just a few of the questions that are being led by researchers using the All of Us research data set. Next slide. And I could not do this work and could not have a session on honoring mothers and African-American women in research without honoring the legacy of Henrietta Lacks. Some of you may know the story of Henrietta Lacks, who was a mother, a caregiver, a community advocate from the rural South in Virginia, whose cells were used without her permission in medical research in the Baltimore area at Johns Hopkins. I was very fortunate when we started the All of Us research program. At the time when we were launching the All of Us research program at the University of Illinois at Chicago, the Oprah Winfrey was producing the movie on the story of Henrietta Lacks' family. And I had a young African-American research assistant. Shout out to Nicole. I said, Nicole, we have to be able to have a conversation about the story of Henrietta Lacks as we launch the All of Us research program. This is why it's so important to have young, innovative people on your team. Nicole actually called HBO to get a copy of the film so we could do a community-based convening to do a film screening. Well, when Nicole called HBO, she somehow got in contact with the agent of the family. So that led to me being connected to 4 generations of the family legacy of Henrietta Lacks. I met her daughter-in-law, Jerry Lacks, her granddaughter, her great-granddaughter, and a great-great-granddaughter. They all came to Chicago to help us talk about the importance of diverse participation in clinical trials. And that's where I first met now my friend, Veronica Robinson, the great-granddaughter, Henrietta Lacks. And this picture that you see here is how we understand community needs. This is a community listening session, multiple community listening sessions that took place in Tuskegee, Alabama. The other thing that I talked about, the other thing that I was committed to when I took on the role as Chief Engagement Officer is nothing about us without us. And I knew I could not do this job without addressing the United States Public Health Service study of untreated syphilis in the African-American male. So I picked up the phone and I called Miss Lily Head. Miss Lily Head is a part of Stories of Our Fathers organization, and that started by descendants who were participants in that study, the United States Public Health Service study of untreated syphilis in the African-American male. Have you all noticed that I have not used the term Tuskegee experiment one time? That is intentional, because when I went to Tuskegee, Alabama, those community members said, we did not ask for that study. And calling it the Tuskegee experiment puts the onus on the community and does not put the onus on the full name of the study, the United States Public Health Service study of untreated syphilis in the African-American male. And also by naming and calling the full name of the study, you tell the history of the study, because there's a lot of myths and a lot of untruths about what that study was. But saying untreated syphilis in the African-American male tells what happened to those families and even the legacy of those families. So I am so proud and so fortunate to be able to work with Veronica Robinson, the great-granddaughter of Henrietta Lacks. And I was so proud and fortunate to be on a panel. We hosted a panel in Macon County convening. You can go on our YouTube channel and watch the convening, where we had also Miss Lily Head, who was the daughter of one of the descendants. And what they talked about in that panel was, yes, the importance of participating in research, but also the importance of researchers looking like the communities that they're researching, and the importance of ethical participation in research, full transparency, understanding the process, and making sure that we talk to communities about the importance of clinical trials, but also that those clinical trials are designed with us and by us. That is what happens when you truly listen to community needs and you talk about this work. The other picture up top is a picture of Dr. Faith Fletcher, who's a researcher that went to Tuskegee University. Now she's back working with that community. And I want to highlight this last picture there on the bottom called Breaking Chains. This quilt that you see in that picture is such a powerful story. And this will take a whole nother workshop in and of itself to really tell the story of this quilt. This quilt was put together by a sociologist, a research project by a sociologist at Tuskegee University, looking at the historical trauma that study caused on community members. And so she used quilting, which is part of our history, to tell the story of the impact of that study. And I got a chance to see that quilt and meet other members of that story. But through community listening, we are now working directly with Macon County on the importance of members of that community participating in research, but understanding how do we both heal the trauma of the past, acknowledge historical wrongs, but move forward so that we can be a part of this research program. Next slide. And I'm almost done because I definitely want to leave some time for questions. So this is another example of us understanding community needs. We still are having these current underway faith-based conversations. So if you are going to be in the Columbia, Maryland area on June 13th, we invite you to go to this, to use this QR code there, to join us at another faith-based convening we have. We are so happy to be partnering with Faith-Based Genomic Research Institute, Baylor College of Medicine, Tuskegee University, and Pyxis Partners to host a series of community convenings with faith-based partners in the DMV area, talking about the importance of return of value and genetic research. Next slide. Again, understanding community needs and engagement partners. This is an example of our partnership with the Black Greek Letter Consortium that's supporting the Mission of All of Us research program. And they've been a key partner in initiatives like Rooted in Resilience, where they actually are going to our historically Black college and university, talking about the importance of research through our Divine Nine. And the Delta Research Education Foundation has an innovative program called the 22 Plus DREF, so 22 Plus Delta Researchers, which are members of Delta Sigma Theta sorority that are scientists and researchers doing this work. So it's so exciting to partner with DREF, the Black Greek Letter Consortium, and others. And as a proud member of Alpha Phi Alpha Fraternity Incorporated, I am so thankful that we are working with the Divine Nine to do this work in partnership with Trusted Messages and moving this work forward. Next slide. And I want to end with talking about 3 research projects that are currently underway. This is one project that was led by Dr. Naia Noel, who's an OB-GYN at Boston Medical Center. She's leveraging the All of Us data set to study hypertensive disorders of pregnancy and the epidemiology of uterine fibroids. I want to read this direct quote from Dr. Noel. As a Black physician, I hope that All of Us research program will work to rewrite the narrative regarding medical experimentation and the past exclusion of marginalized populations and create more participation in research by these populations. To learn more about that study, I encourage you to scan the QR code. Next slide. Next slide. Okay. This is another study looking at using the All of Us data to explore the association between maternal body mass index and the risk of gestational diabetes. Dr. Ghosh's study may identify specific thresholds or categories of maternal body mass index during pregnancy that are related to higher or lower risk of developing gestational diabetes in the later stages of pregnancy. So important, because as we think about nutrition and food as medicine, this study can really help inform some of those initiatives. Next slide. This is a study looking at analyzing genetic and environmental contributions to hypertensive disorders in pregnancy, in bridging genotypes, physiology, and disease through an integrative analytic framework that is inclusive of diverse ancestral populations. Jasmine Mack is a graduate student and fellow at the IRTA predoctoral program. Jasmine hopes to study the synergistic relationship between genetics, what we're born with, environmental exposures, and the social determinants of health. This project is driven by the maternal health crisis in the US and focuses on dissecting the etiology, the origin of hypertensive disorders in pregnancy from genome to exposome and the interaction between that and the aforementioned. Next slide. So these are additional resources that you all can scan to go to and learn more. I know I've talked a lot today about some of the disorders that we see, but the good news is that work is being done to advance this work and to address maternal morbidity and mortality, work by the National Library of Medicine. I hope you can scan that QR code. That's looking at Reading Club on Black maternal health. the Milken Institute report on maternal mortality among vulnerable U.S. communities, and then Every Mother Counts advocacy toolkit that you'll also see here. I hope that you all get access to these slides because that will give you the QR code to these resources, because I don't just like to talk about the problem, but I also like to talk about the solutions. Next slide. So that is it. And now we're going to get to my favorite part of the conversation, and that's the Q&A. Thank you all for joining us tonight. I hope that what I've shared with you has hit home, has resonated for you, and hopefully it causes you to ask the question, and that when you talk to your physician, you talk to your partner about the importance of research, that you can say that, what is the importance of research in my community? How can I be an advocate to advance that research? And that you, along with us, can be a part of advancing and reframing the narrative on diverse participation in clinical trials. Uh-oh, Quay, I'm not sure if it's just me, but I can't hear you.
There we go.
There we go.
The mute button. All right, we're back. Thank you so much, Dr. Watson. We really, really appreciate it. Very, very valuable information. It shows us how important the All of Us program is. We absolutely need to continue to gather this information. It's super important for all of us and for future research. So yes, we're going to move into your most exciting part of the program. We love this part of the program as well. That's the Q&A. If any of you have any questions, please feel free to input your questions in the chat box. We are open for live questions. We do have some questions that have been pre-submitted. I'm going to go ahead and ask those questions, and if time permits, we will try to get to your questions in the box. So feel free to put them in there, and we'll try to get to them as best we can. So Dr. Watson, first, is there any conversation on examples of keeping bloodlines strong?
Thank you for that question, Quay. When I hear keeping bloodlines strong, I'm going to answer that with my own family history. When we talk about when I think of what it means to keep a bloodline strong, I think about what it means to keep our families alive. I think about what it means to ensure that as African Americans, we're doing more than being resilient, but we're thriving. I told you earlier that I would talk more about my family history. I recently lost my oldest brother to complications from colorectal cancer. And when I think about colorectal cancer, a very small percentage of colorectal cancer is related to a condition called Lynch syndrome, which is an inherited condition that you get through your parents. And so when I think about keeping my bloodline strong, I think about the importance of me getting screened for colon cancer, getting my colonoscopy at an earlier age because of my family history. I think about me having a conversation with my brother's sons about making sure they get screened. I think about the importance of having conversations with my siblings about making sure that we get tested to make sure that I don't have Lynch syndrome, because I'm also a participant in the All of Us research program and I receive my data. And fortunately, I don't have the genetic condition that will put me at elevated risk for colon cancer. But my brother had colon cancer and my father died from complications of colon cancer. So something happened in that bloodline. And I want to make sure that I don't inherit that, or that I did not inherit it, and that I don't perpetuate that disease in my life. So the way I keep my bloodline strong is through knowledge. Knowledge is power for me, getting my regular checkups, knowing my family history. That's what I consider keeping my bloodline strong. And so is all of us doing that? I will say that we're doing that because when you participate in the All of Us research program, you have an opportunity to get data back that talks about what genes you may have that may put you at elevated risk for certain conditions. And once you find out that you're at elevated risk for certain conditions as a result of participating in our study, that's a research finding. But we also give the opportunity to have a clinical confirmatory test. And you get the opportunity to speak to a genetic counselor as a result of that. And all of this is for free.
That is vital to know what genes put us at risk. I think you kind of answered my second question, which is how much does it cost to participate?
Yeah, thankfully, as taxpayers, you have already paid your participation in this program. This is a study that's sponsored by the National Institutes of Health, the NIH. So there is no cost for participating in the All of Us research program.
That's wonderful. How long does it take to get results?
That's a great question. Um, to get results back, it can take, we like to give a range or a window. So participating in the program, for example, it took me a couple years before I got my results back because I joined the program in 2018 and I got my, 28, it took almost 3 years for me to get my results back. But we're speeding up that process now. So for most participants, it can take anywhere from 6 months to a little over a year and a half to get those results back, but we're trying to speed that process up. But even that time frame may sound like a long time. That is still quicker than most research studies. Most research studies don't give results back to one. Most research studies don't give any results back, right? We
Right.
hear people participate in research and then we never know what happened with that data. We never know what research came out of that. So the fact that all of us is returning research results back, one, is unprecedented and is groundbreaking. But also the fact that we return research results in a responsible and ethical way by connecting you with a genetic counselor that can walk you through the results you got and that can walk you through how to talk to your provider, your healthcare provider, and other family members.
How can organizations apply for funding for this?
I would encourage any community-based organization, any researcher to, on a regular basis, to look at the NIH's website for any active funding across all of our institutes and centers. But if you are looking specifically to apply to the All of Us research program, you can go to our website, and then within our website, you can go to funding opportunities, and that will walk you through how to apply.
Do HIPAA laws and confidentiality standards apply to genealogy research?
Great question. I hope all participants ask, anyone who wants to participate in research, you should always be asking that question of what happens to my data? What privacy measures are in place? So do HIPAA laws apply? We have something in place so the first answer is yes, HIPAA laws and privacy laws do apply. Requirements do apply to the All of Us research program. And so one of the things we have too is called a certificate of confidentiality, meaning that the data that we collect from the All of Us research program cannot be shared with anyone. It can't be used for any legal purposes, for any other thing other than to analyze that data for research questions through the All of Us research program.
Wonderful. This is a big question. I know a lot of folks want to know the answer to this. Is there validity in 23andMe? How might I utilize the information from those results?
So I'll answer that question by saying, as a federal employee, I'm not at liberty to talk about a industry-sponsored program, but I'll talk about genetic testing what I'll say about that. So if you're doing any genetic testing that's from a commercial entity, I would often encourage you to talk to your provider about that genetic testing. So if you got genetic testing from a commercial entity, you should talk to your provider, whether that's a nurse practitioner, a family doctor, or anyone, about what results you got from that commercial entity to see if and how those results are applicable to any of your clinical conditions. And I really want to give a shout out to the importance of genetic counselors. I can't stress enough, particularly we need more people of color, more women of color actually going into the field of genetic counseling. So if you're listening and you have a child that's in college thinking about what careers of the future should I be thinking about, think about genetic counseling. One of my colleagues, Dr. Altavis Ewing, she's one of the few African-American women that's a genetic counselor and a PhD researcher in this work. So we need more Dr. Ewings doing this work.
Absolutely, absolutely. I think we're going to move to the chat right now. If you have any questions, please feel free to put your questions in the chat. And here's a question right here. Are opportunities paid versus unpaid? What types of costs are covered? Travel, overnight stays that may be an incentive or barrier to possible participants?
Great question. So in research, and this actually came out a result of the United States Public Health Service study. An entity came out from that called the Institutional Review Boards, IRBs. IRBs oversee the ethical process and the ethical implementation of research. And one of the things that the IRBs stress is that research can't be coercive. So the word paid was used. The word that we use in research is compensated for time and effort. So yes, the All of Us research program does compensate our participants a small compensation for participation. And typically the costs that are covered in the research program, anything that's collected in the research program is done at no cost to the participant. So the blood draws, the saliva sample draws, the survey completion, physical measurements that are taken. All those are covered costs in the research program. And in terms of travel, we've really tried to make participating in the All of Us research program as convenient as possible. And we have multiple locations across the US. So therefore, overnight travel is not required in most places, and no overnight stay is required for this particular type of study that we're collecting. And also, we have a mobile engagement unit that goes across the US, actually going to communities that don't have access to the academic medical centers that are participating in All of Us. You can participate by finding out where our mobile engagement asset will be.
That's wonderful. Wonderful. Let's see. Thank you for the information about the Tuskegee. My understanding is that these men were injected with syphilis. Is that true? That's what worries me about volunteering for research. Can we trust placebos? That's a good question.
That's a great question. And so I'll start off with, I would encourage you all to go to the CDC's website to read the write-up on the story of the United States Public Health Service study of untreated syphilis. Because that's the fact that, the story that those men were injected with syphilis was not the study. That's why I said the name of the study, untreated syphilis. The United States Public Health Service study of untreated syphilis was looking at men who were either had syphilis when they enrolled or acquired syphilis during the time of the study, and following the progression of those men without them being treated. And one of the reasons why that study was so unethical on many levels was because during the time of that study, that penicillin was invented. Penicillin was discovered. And we knew from science that penicillin was an effective treatment for syphilis, but these men were not offered that treatment. So that study was unethical on several areas. One, informed consent was not even a thing then, and it wasn't in place. There was no institutional review board. There was no agency overseeing the ethics of that study. The men were not, they were not informed and educated from a way that met them at their literacy level, their education level, to talk about what they were participating in. And then there was no conversation with them about the risk or benefits, because again, the institutional review boards didn't exist at the time when that study was developed. So when you participate in research now, as a researcher, I've done a study where I've compared the difference between a placebo, which is a non-active medication, versus a new innovative medication. One study that I was designing, the institutional review board said that made it clear that they wanted to know from me, was I withholding any known treatment? And the answer was no, because that would have been unethical. For me to give someone with cancer, for example, a placebo and not give them a known treatment that I know works versus someone else who I'm trying to do a new treatment, that's an unethical study, and that would not get past the IRB in this day and age. So when we talk about placebos, we have to talk about them in the context of the design of particular studies. So placebo is a non-active treatment, but it differs across the study. So is there justified medical mistrust that we should have? 100%. Are there systemic racism that still takes place today? 100%. But are there things in place that can control and mitigate the risk for unethical research? 100%. And that's why I can sleep at night by being a researcher, because there are things in place that protect research participants.
And you're a part of the process, which is very
That's right.
I mean, you're supervising this, you're watching over this. So very important. How do you get into genetic counseling?
Great question. So genetic counselors is actually, it's a master's trained program. I don't think that there's many bachelor's programs for genetic counseling. Most of the genetic counseling programs I know it's a master's program. After you major in pre-med, science, sometimes you don't even have to be a science major as long as you fulfill the pre-requirements to get into that master's program for genetic counseling. That's how you can become a genetic counselor. I would encourage you to look at programs throughout the US for becoming a genetic counselor. It's typically a master's trained program. Some people do go on to get a PhD or a doctorate, but those are people who do want to do research in genetic counseling. Wonderful.
Thank you. Thank you. Is there an ideal age for participants?
Great question. I apologize. I missed this in my one of the things that I used to get really frustrated. The first answer is no, there's not an ideal age. Right now we are enrolling participants, anyone that is 18 and older, It doesn't matter if you have a certain condition, if you don't have a certain condition. If you're 18 and older and you're able to sign the informed consent or go through the informed consent process in English or Spanish, you are able to participate in the All of Us research program. And we hope that to put the enrollment and engagement of pediatric populations in the future of the All of Us research program, because we know it's so important to engage people across the lifespan. One of the frustrations I used to have as a researcher was this thing called inclusion exclusion criteria. These are things that research study are in the design of research study that says that if you have this, you have to have this to be included. That's an inclusion criteria. Or if you have some of these other things, you will be excluded. So often I would see African-American patients being excluded from clinical trials because they had hypertension, they had diabetes, what we call a comorbid condition. And oftentimes that prevents certain populations from participating. So All of Us was intentionally designed because we're not an intervention research study. We're not looking at a new device. We're not looking at a new drug. There's no placebo involved in our research. We are literally collecting data to make that data available to researchers. Therefore, we don't have inclusion and exclusion criteria other than currently 18 or older, and able to go through the consent process in English or Spanish.
We have time for one more question. Yes. Our participants provided hard copies of their results from the genetic study to share with their physicians.
Yes, they are. And that is something that we found out through community conversation before we enrolled our first participants. That was the feedback from the community. They said, you know what, you can't just give these results to participants and then they walk away thinking that they're supposed to somehow go to the doctor and be able to explain these results. So you can get a hard copy, and that genetic counselor for free can walk you through how to talk to your provider about what was in those results. And the other step forward is that I want to note that the results you get from the All of Us research program are research results. But we partner with an organization called Color Health that allows you to get a clinical confirmatory test that will allow you to take that test to make any clinical decisions that you need to make.
That's wonderful. Very, very, very comprehensive. Do we have time for one more? Maybe, yes. You mentioned something about Columbia, Maryland. What was that?
Yes, so I'm not sure if my partners from Pixis can put that up, but we have an event that's happening in Columbia, Maryland at a faith-based organization on June 13th. If we can put that slide up or make it available on your website, the event is on June 13th, I believe at 6 p.m., happening at one of the local churches. At least if you want to text me that information, I can say it real quick as well, if we're not able to bring it up.
I'm not sure.
Okay.
We can definitely make sure we get that information out. We'll make a note of who asked that question as well. I see the name of the person who asked the question.
Awesome. Thank you.
Sounds good. All right, we are just about at time. I don't know if is there another quick question that we can get in, or do we need to end now? Might need to end now. Any questions? All right, I think we're going to need to, is that the
There it is.
There you are. Okay, and there's a QR code there too.
That's right. We would love to see you all. I will be there in person, and some of our other partners, Dr. Deborah Murray from Baylor College of Medicine will be there, and Dr. Shaka Cunningham, African-American geneticist, will be there, as well as Dr. Clayton Yates, a friend and colleague of mine. It's going to be hosted by Dr. Harvey, which is the pastor of that faith-based community there.
Wonderful. Someone just asked, when will you be in New York?
Invite us, and we will try to find a date and time and to come to New York to do some engagement events there.
Wonderful, wonderful. Dr. Watson, we want to thank you so much for this information. This is rich information. It's very important, very worthwhile. It's important for all of us to understand our genealogy and to keep our bloodline strong. So I hope that everyone will utilize this information. You'll take advantage of the QR codes. And I hope that everyone is interested in participating in the All of Us research program. Thank you so much for joining us this evening. Thank you to NIH, the All of Us research program. Special thank you to my MoCA Moms National Board, So to learn more about the All of Us research program and how you can become involved, there's a QR code here. Please visit bit.ly/MochaMomsAOU. You see that on the screen. Please take advantage of that. There's a lot more information, and we're hoping you'll be interested in participating. So with that, we thank you. Thank you so much. We really appreciate all of your information. And thank you to Mochas and friends who joined us tonight. We hope the information was worthwhile, and we hope it will help you and your families. Thank you again. Good night.